So
Absolutely.
we're going to move on now, and we're going to transition back to one of the physicians who is with us today, Dr. Pete Voorhees. Pete, I'm going to turn it to you. The unfortunate reality is that myeloma, although we have better drugs, as I described up front, unfortunately, myeloma typically does come back. And so we've asked you to cover the topic of when myeloma comes back. And I'll turn it to you, my friend, to guide us over the next 15 minutes.
Very good. Thank you, Joe, so much for allowing me to participate in this program today. And it's great to see the IMF crew and the Levine Cancer Institute crew here today. So I'm going to be talking about when myeloma comes back. And I'm going to start with a case. This is a 67-year-old Black man with IgG lambda multiple myeloma. The patient had stage 2 disease and an 11-14 translocation that Dr. McHale referred to previously at initial diagnosis. The patient has diabetes and high blood pressure. He got 4 cycles of Revlimid, Velcade, and dexamethasone induction treatment, followed by an autologous stem cell transplant, and went into a complete remission. Treatment was complicated by Velcade-related neuropathy with pain. 3 months after transplant, the patient started Revlimid maintenance therapy and continues it to this day, 4 years later. 3 months after, aside from low-grade fatigue and intermittent diarrhea and muscle cramps, the patient's done well with therapy and is able to live his life with minimal impact on quality of life. His Velcade-related neuropathy is well controlled, but there is residual numbness and tingling in the feet, for which he takes Cymbalta. He now presents with worsening low back pain. The M spike or M protein has risen from undetectable to 1.1. Plain x-rays of the spine are unremarkable, but an MRI reveals a new bone lesion in the lower back. So what do we do next? So what does it mean when your myeloma comes back? So the National Cancer Institute describes progressive disease as cancer that is growing, spreading, or getting worse. They define relapse as the return of a disease or the signs and symptoms of a disease after a period of improvement. And we tend to use these terms interchangeably, myeloma coming back, disease progression, progressive disease, disease coming out of remission, relapse. Basically, all that means is that the myeloma cells are now growing and dividing, and the burden of disease is increasing over the course of time. So there are a number of different ways to identify relapse. There are blood and urine studies that you can do to look for that M protein. There are some patients who do not have myeloma cells that make antibody anymore, and there we may rely more heavily on bone marrow biopsies and x-rays of various sorts to identify whether their disease is relapsing or not. As far as imaging is concerned, we have plain x-rays, we've got CAT scans, we have MRIs, we have what are called PET-CT scans. These are very valuable in assessing whether a patient has bone disease and whether that bone disease is getting worse. The PET-CTs, the CAT scans, the MRIs, this can also help us identify whether the multiple myeloma has learned how to grow outside of the bone marrow, something we call extramedullary multiple myeloma, which typically indicates a more aggressive version of the disease. And then there's obviously clinical symptoms that we have to be very attuned to. So if someone comes with new progressive bone pain that we can't explain by any other means, that's something that we have to chase down. Is the patient coming with worsening fatigue for no good explanation? These are all things that can be indicators of relapse. So these are the National Comprehensive Cancer Network guidelines for relapsed multiple myeloma for patients who've had 1 to 3 prior therapies for their disease. I'm not going to go through all of these. Suffice it to say that there are 11 cocktails or so of myeloma drugs listed here that are considered the preferred regimens, 9 of which have level 1 evidence behind them. Level 1 evidence means that these regimens or cocktails were validated by large randomized clinical trials showing their superiority to previous standards of care. And there are a couple on here that are very important, but don't have that level 1 evidence. There are also 15 other recommended regimens that I don't have outlined here, and there are 15 regimens useful under certain circumstances that we can also use. That translates into 41 regimens for relapsed multiple myeloma. So how the heck do we decide, what we're going to use for a particular patient? So this is a goofy acronym that I came up with a number of years ago, and I've tweaked it a bit over the course of time. This is PAPS, or the Blue Ribbon Approach to Treatment of Relapsed Multiple Myeloma. So the P stands for past medical history. Also, I think we should put in patient preference here. What comorbidities will impact tolerability of therapy? What is the patient's preference? Do they want, an all-oral regimen? Are they okay with intravenous infusions, for example? The A stands for adverse events. What toxicities were experienced with prior therapy? We talk about biochemical versus clinical relapse and progression. What that means is biochemical progression is when the numbers or M protein is rising, but the patient feels the same. Clinical relapse means is that they've got new symptoms related to that relapse. There's standard risk versus high risk disease biology that may impact, how we change treatment. And then the T stands for treatment history. And specifically, has the myeloma become resistant to specific drug classes? And that can kind of guide us as far as the best next steps to treat the patient. So going back to our patient, past medical history includes diabetes, so we have to be very careful with the dexamethasone and get rid of it quickly if we can. The high blood pressure is important because carfilzomib or Kyprolis and the steroids can aggravate high blood pressure, and we have to monitor that carefully. Adverse events. In this particular case, the patient had Velcade-related neuropathy with pain, so we may want to avoid that particular agent at relapse. Biochemical versus clinical relapse. This patient has a clinical relapse with increasing pain and a new bone lesion. So we need to use a treatment that has a high likelihood of success and producing a deep response. Standard risk versus high risk. This 11-14 translocation that I mentioned before is considered standard risk, but we may be able to exploit that therapeutically later on, and I'll talk about that later. And then treatment history. This patient was on Revlimid maintenance therapy, and their disease is growing in the face of Revlimid maintenance therapy. So a Revlimid-based strategy may not be this patient's best option. So going back to these preferred regimens, these 11, I've basically struck out anything that has Revlimid in it, and I've struck out anything that has Velcade in it because of this patient's neuropathy and pain. So I have 6 regimens left, 4 of which have level 1 evidence behind them. And I'm going to talk with the patient about these 4 regimens with level 1 evidence. And these are the randomized phase 3 studies that basically validate these 4 regimens that I'll talk to the patient about. So these are randomized phase 3 studies that either took Pomalyst and dexamethasone or Kyprolis and dexamethasone and combine them with one of these CD38 antibodies, either isatuximab, which is called Sarclisa, or daratumumab, which is called Darzalex. And to make a long story short, when you add a CD38 antibody, either of them, to Pomalyst and dexamethasone, or to Kyprolis and dexamethasone, you reduce the risk of myeloma progression and death by 37 to 47%. So back to our patient. After discussion, the patient chooses subcutaneous daratumumab or Darzalex with Pomalyst and dexamethasone. Pomalyst is oral. The patient doesn't want to go back and forth to the infusion center. He achieved a very good partial response, or 90% or greater reduction in disease burden in the first 4 cycles of treatment. 2.5 years later, the patient experiences new right hip pain. The M spike remains stable at 0.1. However, their serum free lambda light chain level has increased from 24.5 to 112. This is something that we call free light chain escape, and it's why it's so important to measure both the SPEP and the serum free light chains over the course of time. An MRI of the hip reveals an impending fracture for which the patient undergoes a total hip replacement. So after recovery, what do we do next? So again, going back to the PAPS acronym, the past medical history remains the same. Adverse events, again, the Velcade-related neuropathy that we have to be aware of. Biochemical versus clinical relapse. This patient has a clinical relapse. Standard risk disease, again, they have this 11-14 translocation, and we're going to talk more about that in a moment. And then importantly, as far as the treatment history is concerned, this individual now has disease that's become resistant to Revlimid, Pomalyst, and Darzalex. So we will prefer to go with a regimen that perhaps does not contain those specific agents. So the 11-14 translocation, and Dr. McHale previously showed us that this is actually more prevalent in our black myeloma patients than it is our white multiple myeloma patients. This is present in about 15% or so of multiple myeloma patients. And there's an oral medication called venetoclax or Venclexta that works very well in this subset of myeloma patients. It doesn't work very well for those that don't have this 11-14 translocation. And what I'm showing here is a phase 3 study that looked at Velcade and dexamethasone with or without this oral drug venetoclax. And to make a long story short, the introduction of venetoclax with Velcade and dexamethasone reduced the risk of myeloma progression and death by 88%, which is really quite a remarkable result. So going back to our patient, he chooses to participate in a phase 1-2 clinical trial with venetoclax, Kyprolis, which is in the same family as Velcade, but doesn't have the same degree of neuropathy problems, and dexamethasone, and goes into an MRD negative complete remission. He requires the addition of a second blood pressure medication to his regimen to control his blood pressure, but is otherwise doing well. 3 years later, the M spike has risen to 0.5 from undetectable. The serum free lambda light chains are going up again. He has no new symptoms, and imaging reveals no new or larger bone lesions. The bone marrow shows 10% myeloma cells, up from the previous of undetectable. So what do we do next? So these are the NCCN guidelines for relapsed multiple myeloma for 4 or more prior therapies. And what you can see here is that the choices are not as abundant as they were previously. So we have these 4 specific regimens here, selinexor, Xpovio, and dexamethasone, belantamab mafodotin, and the 2 CAR T-cell products, ide-cel and cilta-cel. So going back to our patient, again, past medical history, diabetes and high blood pressure. We need to get rid of that dexamethasone at this point. The adverse events, these are not probably as important because we're going to go to something completely different at this point. This patient is in a biochemical relapse this time, not clinical relapse, which gives us a little bit more flexibility about new treatment start. Standard versus high risk, I would argue that once your disease becomes this resistant, there's no such thing as standard risk disease. And then going to their treatment history, they now have disease that's become resistant to Revlimid, Pomalyst, Darzalex, Kyprolis, and venetoclax. So we want to either avoid regimens with these agents or use them with other agents that the patient has not previously seen before. So for example, we could go back to Pomalyst, but pair it up with cyclophosphamide, which this patient hasn't had before, or Empolicity or elotuzumab. So let's talk a little bit about triple refractory disease. This is disease that's become refractory to a proteasome inhibitor, an immunomodulatory drug, and a CD38 antibody. Suffice it to say that before we had some of these newer agents, median overall survival was only approximately 9 months. So we now have a completely new class of agents that target something called BCMA. BCMA stands for B-cell maturation antigen, and this is a protein that is expressed on the surface of plasma cells, including the cancerous plasma cells of multiple myeloma. And there are a few different ways that you can target BCMA in multiple myeloma. There's what's called an antibody drug conjugate, which is exactly what belantamab mafodotin is. There's a bispecific antibody, which is what teclistamab is. And there are the CAR T cells. These are genetically re-engineered T cells that basically can identify and kill anything that has BCMA sitting on its cell surface. And we have 2 FDA-approved products now in ide-cel and cilta-cel. So the first thing I'm going to do is just quickly talk about teclistamab, which is the BCMA-targeted bispecific antibody that we hope will become FDA approved as early as August of this year. So this is a bispecific antibody that was given as a subcutaneous injection to patients who had heavily pretreated, very resistant multiple myeloma. This was a high-risk patient population, and close to 80% of them had this triple refractory disease that I referred to before, where the expected survival is less than 1 year. And what you can see here is remarkably, over 60% of the patients responded to treatment, and the majority of those patients had at least a 90% knockdown in disease burden. When you look at 9-month progression-free survival, close to 60% of them have not had disease come back, which is really quite remarkable. So their progression-free survival is looking better than the expected overall survival historically. So this is something that's poised, to completely change treatment for patients with relapsed refractory multiple myeloma. As Dr. McHale pointed out, when we see something good in the relapsed refractory space, we like to bring it up earlier in the course of therapy. So there is a randomized phase 3 trial looking at teclistamab for patients in early relapse, and we will be seeing studies in the newly diagnosed setting as well. I'll lastly talk about the CAR T cell product cilta-cel. Again, this is a BCMA-targeted CAR T cell therapy. This was initially tested in patients with heavily pretreated, very resistant multiple myeloma. And despite that, nearly 100% of the patients responded to therapy. 95% of the patients had at least a 90% knockdown in disease burden. And over 80% of patients went into complete remission, many of which had minimal residual disease, negative complete remissions. When you look at progression-free survival, what you can see here is that 2 years out from CAR T cell administration, 60% of these patients still are alive and their myeloma has not come back. For those that have achieved a complete remission and are MRD negative, all of those patients are alive at 2 years without their myeloma coming back, which is really incredible. So again, we like to move things that are very promising in late relapse up into the earlier treatment continuum. I will let you know that there is a phase 3 study that is gearing up, looking to see if this CAR T cell product, cilta-cel, can replace transplant as consolidation after initial therapy for newly diagnosed myeloma patients. So going back to our patient, he chooses ide-cel followed by iberdomide maintenance as part of the KarMMa-7 trial, and achieves an MRD negative complete response. Treatment is complicated by moderately severe cytokine release syndrome early on and low-grade neurologic changes, all of which resolve by the 3rd week after treatment. 2 years later, he remains in an MRD negative complete response and is tolerating iberdomide maintenance well. So to conclude, myeloma does come back, but we have many effective tools and patients are living longer than ever. Our example here, this patient is well beyond 10 years into their treatment course and they're in an MRD negative complete response. Precision medicine is emerging in multiple myeloma. I gave you the example of venetoclax for 11-14 translocated myeloma. I think it's safe to say that BCMA targeted treatment is transforming the treatment of multiple myeloma. I want to strongly emphasize that clinical trial participation is key to improving the care for all patients. Back to Yelok's point earlier, paying it forward is incredibly important to move the field forward. Speaking of going forward, it's absolutely critical that we improve access to the most effective therapies, bringing the most effective therapies in late relapse to early relapse and newly diagnosed disease. Optimal treatment beyond BCMA-targeted therapy. What do we do for those patients who relapse after they've had these wonderful drugs? And we need to double our efforts in patients with high-risk features, whether this is the frail patient population with lots of comorbidities or those that have very aggressive high-risk disease biology. And with that, I'll wrap up. Thank you.
Great. Well, thank you so much, Pete. That was great. Wow. I mean, you squeezed a lot into that period of time. And, you know, on the one hand, it's always discouraging to know that this disease comes back. But on the other hand, how encouraging to see so many of these incredible new therapies available. So let's move into some questions. We've been getting a lot of questions coming in. I know we're running a few minutes late, but I don't want anybody to worry about that because we're going to be able to catch up time to some degree. And it's okay if we run a few minutes because this is just such an important topic. But for those who've just been speaking, we'll bring you all together here with Yelek, Tiffany, and Pete, and we'll start looking at these different questions. Someone asked a very interesting question around iron levels and myeloma. And it's actually pretty rare for myeloma to initially present with really high iron levels, although that can be the case. But maybe we'll start with a question that came out of that, which was, and maybe Yelek, I will turn this to you for a moment, was, you know, should, and I know I made comment to it, so it's better to hear it from you, you know, would this group recommend seeing a myeloma specialist for their treatment? Is that something we sort of universally recommend, or what is your take on that?
So as a patient, I believe one of the key differentiators of those that end up living long and well with myeloma and that don't, one of the key differentiators is whether they have a myeloma specialist on their team, whether it is some going and consulting with one, or in my case, which I really think is more important, establishing a long-term relationship with a myeloma specialist. Because then, as you said, Dr. Joe, they will not be treating my myeloma, they will be treating me and all of me more holistically. But I think it's also important to understand that, as Dr. Pete was showing, you go from having data to having guidelines, and then depending on the clinical judgment of your myeloma team. So I believe having a myeloma expert would allow you to have the best clinical judgment on your side.
That's really helpful. And you know, I have to say, this is so much of what I do and have been doing for the better part of 20 years, where I work very closely with community oncologists who are taking care of patients and sort of serve as an expert guide and help along the way. And, you know, sometimes patients feel, oh, I'm going to be unfaithful to my community oncologist if I go see Dr. Joe. And we try to reassure them that it's actually a partnership. We work together. And we become a lifeline that can really help them in different situations. So I think that's really, really important. Pete, maybe we'll bring this question to you. Lots of really good questions, but here's one that says, does the patient become resistant to all drugs in a quadruplet if they did not achieve MRD negativity? So maybe we can help understand a bit about the concept of resistance to drugs.
Yeah, so I would say, generally speaking, no. You know, just because you haven't, I mean, MRD negative just means that we can't see it with our most sensitive techniques. It doesn't mean that we've knocked off every last myeloma cell in that patient. And just because we can see a trace amount of disease left behind, that does not mean, you know, that these drugs have stopped working. When we apply these 4-drug regimens, or if we apply a 3-drug regimen for that matter, you know, we typically aren't using all 3 of those drugs or all 4 of those drugs indefinitely until the patient's myeloma comes back. We typically are using these more aggressive strategies to knock down the burden of disease definitively early on. You know, we may do the consolidation, you know, transplant like you talked about in select circumstances, but then we move on to a maintenance strategy. So most of the patients who are having their myeloma come back for the first time, while they may have disease that's growing on Revlimid maintenance, for example, which we see a lot here in the US, you know, their disease is still sensitive to the Darzalex they got at initial treatment. You know, it's still sensitive to the proteasome inhibitor and the dexamethasone that they got initially. So you can go back to those classes of drugs and use them again.
That's really very helpful. And I think that's where, even in light of what Yellick just shared with us, sometimes that's where it's helpful to have an expert to try and use the tools that we have. And sometimes you go back to the toolbox and use a similar, if not identical, tool that you've used before. Here's another great question that I'll take on, saying, what test can I monitor to see if my treatment is working toward remission? And we've kind of made mention of this going through, but let me just quickly help us understand. I use this analogy even with my patients. It sounds awful, but myeloma is like a crime scene, right? It doesn't really have one piece of information that tells you the whole story. So as I think Pete mentioned a couple of times, depending on the patient's circumstance, we follow where the disease is most measurable. Obviously, sometimes we need the bone marrow because that's where the disease starts and grows. But those cancer cells in the bone marrow release that bad protein into the blood. And so typically we do the blood measures of that protein. And sometimes it's what we call the M spike, or the whole monoclonal protein. And sometimes it's just little bits of it, what we call the light chain, which is why we measure both the serum protein electrophoresis and the light chain. Now, sometimes even then we can't measure it in the blood. It can only be measured in the urine. So we have the bone marrow, we have the blood test for the abnormal protein, we have the urine test for the abnormal protein. But then, of course, all along the way, the other sort of basic blood tests that tell us about someone's blood count levels, their kidney function, their other so-called biochemistry, all becomes really important. So testing all of those things as we go through. We don't necessarily have to do a bone marrow every single visit, of course, but we do the blood tests throughout. And then that'll help us determine how deep someone's remission is. That's another word that sometimes gets confusing for people, because you hear the word remission, you think, oh, my cancer is gone. Well, actually, we use the word remission for any kind of reduction in the size of the myeloma. Like, you think, for example, simply of a lung cancer. If someone has, sadly, a lung cancer that's 10 centimeters long and they get treated and it drops to 5 centimeters, they're not in complete remission, but they have some degree of remission, meaning it has shrunk down. It's shrunk down by half. And that's the same kind of same kind of concept we use in myeloma, that if whatever measure of the myeloma goes down by 50%, we call it a partial remission. If it goes down by 90%, we call it a very good partial remission. I know it sounds pretty simple. And then if it goes down by 100%, we have what's called a complete remission. And then even then, we have a deeper level to a complete remission, what Pete talked about, what's called MRD, or minimal residual disease negativity, where we can't even find any of it in the bone marrow. We go searching for it, like trying to find dirt with a wet Q-tip. Like I can't seem to find anything there. And that's the deepest level of remission. And when I started our talk talking about depth and duration, we know that generally speaking, the deeper remission relates to a more durable remission. So I think that's hopefully helpful to the individuals who's asked that question. Our time is almost gone, but I got to direct the last question to Tiffany and ask you, Tiffany, again, you gave us such a wonderful overview, but if you could give a single piece of advice to the support groups and individuals in support groups, because we have some of our support groups here on the line with us today and listening in on this, when it comes to community engagement, what would be that critical piece of advice that you would give to them?
Oh, wow. No pressure, Dr. McHale. Man, if I'm speaking directly to the folks that are in the support groups, I would say to share your stories and share them loudly, because honestly, when we do community work, a lot of people want to know, the data and the numbers and things like that. But what's usually missing is the story and the humanity behind the work that happens in communities. And those are the things that are very, very special. And so anytime that we can attach a patient voice or a patient story or an experience to programs that we want to do in the communities, it just makes it so much more powerful sometimes to everyone, to the funders, to the community, to people kind of connect and engage, especially if the person is somebody they can relate to. So that, it just off the top of my head, that's probably the one thing I would say to the strong folks that are in the support groups, is to feel free to share those stories and to let your voice be heard about your experiences, the good and the bad, and how we can kind of fill gaps and use that to lift up the communities at large.
That's fantastic. Beautifully put. And hopefully today you've heard Yelek's story. And what a great segue to when we come back from our break. I'm going to talk a little bit about our toolkit and our website where there are stories shared. But even more importantly, we're going to hear from patient, pastor, and entrepreneur Robert Pugh shortly, and we're going to hear his story. So just to wrap up before we go to the break, there was a great question about neuropathy. I'm going to hold on to that question because we have Amy Pierre with us, who is an expert in supportive care and myeloma, and I'm going to get her answer that. And then lastly, we had a question about ongoing clinical trials, and I'd encourage you, someone who wants to learn more about clinical trials, you can go to myeloma.org, which is our IMF website where we talk about that, but also clinicaltrials.gov, G-O-V, is where they're all listed. But I got to tell you and warn you, there are going to be over 4,000 trials listed for multiple myeloma. So there's quite a list, which is why we try to make it a bit easier at the website.